So what are the basic difference between spontaneous breathing and mechanical ventilation? In spontaneous breathing, what we are doing right now is at the end, remember at the end of expiration, the pressure in the pleural space is zero at the end of, again, all of us, during inspiration, during expiration, at the end of expiration. And when we want to take a breath in right now in spontaneous breathing, the intercostal muscles constrict, diaphragm goes down, that brings the pleural pressure down compared to airway pressure, and air gushes in depending on how strong you are. So the ventilation is controlled by the flow of air, which is regulated by the pressure. And when the flow slows down, the signal goes to the brain to exhale. The pressure, we exhale, the pressure comes back to zero in the pleural space, and that cycles the breathing. That's what the spontaneous breathing is. So during spontaneous breathing, your thoracic pressure goes down. Pressure during inspiration goes down, and during expiration it goes up. And remember, all the major blood vessels, the IVC and SVC, they enter the thoracic cage. And so this intrathoracic pressure affects the flow of blood into IVC and SVC. So in spontaneously breathing during inspiration, as the pressure goes down, there is more blood coming to the right side of the heart from IVC and SVC, and your cardiac output goes up. During expiration, it's exactly opposite. The cardiac output and your blood pressure will drop. Now, this is not so much important in a patient who is euvolemic, but when patients are hypovolemic, this fluctuation in venous return and cardiac output may be significant, that your blood pressure may drop with changes in ventilation. And with mechanical ventilation, it is exactly opposite. Now you are using a machine to push the air in during inspiration, so that increases the intrathoracic pressure, and during exhalation, the pressure goes down. So the whole pressure dynamics is completely opposite during spontaneous breathing and mechanical ventilation. And the main effect is on the venous return, which you need to understand that what happens. You can imagine a patient who is struggling to breathe for a long time, and eventually you intubate them. They already have, worked out a lot. They have a lot of insensible losses. They are hypovolemic. And when you intubate them for the first time, they usually become hypotensive. So, and one of the major reasons is because of the venous return that went down with mechanical ventilation, and you need to volume load them to bring them back to the euvolemic state. So, what are the indications? So, this is basically, I like this particular way you look at the respiratory failure. It's like a balance. On the left side, you have a load, and on the right side, you have the strength. All of us, we have a load on the respiratory system. The load is to get rid of CO2. That is the single most load we have on the system. And it can be, classified into different categories. Restrictive loads is basically restriction to airflow, bronchospasm, asthma, COPD, obstructive sleep apnea, or any foreign body. Lung elastic loads is basically diseases of the lung, like pneumonia, pulmonary edema, CHF, anything that prevents expansion of alveoli, that is lung elastic load. And chest wall elastic load, anything, diseases of the pleural space, pleural effusion, pneumothorax, and things like that. And your minute ventilation load, this is something that we usually don't look into consideration, but it's a load. When you are hyperdynamic, when you're septic, or a thyroid storm, somebody is working too hard to breathe, the end product of energy metabolism is carbon dioxide. So then you produce a lot of carbon dioxide, and your body has to get rid of it. So as you produce more, you need to get rid of that CO2. So that is basically a minute ventilation load. Your minute ventilation has to go up to accommodate for increase in CO2 production. And on the right side, you have the strength, your ability to cope with this load. And the depressed drive basically comes from the CNS, either drug overdose, sedative, narcotic overdose, or some kind of brain diseases, brainstem stroke, and brain death. Muscle weakness, you all are familiar with Guillain-Barré or myasthenia gravis, which are common muscle disorder. And also now the new kids on the block is not really new, but you do need to recognize ventilator-associated diaphragmatic dysfunction and intercostal muscle weakness, which we create by putting the patients on mechanical ventilation and not let them use those muscles. And then impaired neuromuscular transmission, basically with Guillain-Barré syndrome and any kind of spinal cord disorders. So if whenever you have this balance compromise, that's when you go into respiratory failure and you need to intubate the patient. Okay. So, the factors that is going to affect your CO2, alveolar CO2, arterial CO2 is only two things. It's a ratio between the VCO2, the amount of CO2 that we produce, and actual alveolar ventilation. Now, alveolar ventilation is a difference between your minute ventilation and dead space ventilation. So you do need to have, normally on an average, we need to have 5 liters of minute ventilation to get rid of the 200 ml of CO2 that we produce every minute. All right. If our minute ventilation is less than that, then your CO2 is going to start rising. And you need a cardiac output of 5 liters per minute to bring this CO2 to the lungs for the lungs to get rid of it. So in a patient, if your cardiac output drops from 5 to 2.5, every minute you are going to retain only 100 ml of CO2. And in order for you to get rid of that CO2, your minute ventilation has to double. So that's what typically happens in patients who are hypotensive, in shock, either cardiogenic shock or septic shock, when nothing wrong with the lungs, but they still become tachypneic. Why do they become tachypneic? Because your body has to increase that increases the workload on the respiratory system. And eventually you are going to fail because you cannot keep maintaining that load on the respiratory system. You are going to get tired out and you are going to fail. So that's basically the load of, that's how you approach the CO2. And, hypercapnia, you don't want to dwell on the slide again, but it's increased VCO2, decreased minute ventilation, and actually we are looking at decreased alveolar ventilation, an increase in the dead space. Okay. For CO2, perfusion is never ever a problem. Once the CO2 reaches the lung, it is very easy. CO2 is less dense. It is 20 times more diffusible than oxygen. And it's almost unheard that CO2 perfusion is a problem for CO2 retention. It is always the other three are the problem. Whereas compared to oxygen, there are various factors. This is a busy slide, but there are various factors that is going to affect oxygen coming into your body. Okay, and it starts with the barometric pressure. Everyone knows about these are non-variable factors. What we breathe in is a room air which contains oxygen and nitrogen, right? 20% oxygen, 80% nitrogen. So that's PiO2 stands for the pressure of oxygen that we are breathing in. And then at the alveolar, CO2, as I said, it is much more easily diffusible than oxygen. So at the level of alveolus, before oxygen can come in, CO2 quickly goes into the alveoli. So you have three gases in the alveoli. And the amount of oxygen that can come in is basically the oxygen that you breathe in, FiO2, and then you need to take out the CO2 because this CO2, the amount of CO2 that comes in, it is going to reduce the amount of oxygen coming in. So your actual alveolar equation, to keep it simple, is 7 times FiO2 minus PCO2. Now this is not the accurate number. The actual physiological numbers are somewhat different. To make it easier, and if I really recommend that whenever you look at the blood gas, you always look at the arterial to alveolar oxygen difference, because that is important. Anyone can have a normal PaO2, arterial oxygen, but if patient is requiring 70% oxygen, that's not normal for that patient. So you need to understand that, right? So I always do that whenever I interpret ABG, and you should do that, make it a habit. So the amount of oxygen that can come in is your PiO2, that basically is FiO2, and barometric pressure is not going to change. It is important for you to know as a provider, because if you end up from Woodhull and you go into Denver or some higher sea level, your barometric pressure may be lower. And in patients who are COPD, when they take an airplane, what is the airplane pressurized to? It's 10,000 feet, right? So your barometric pressure is lower in the airplane than what we have. And some COPDers may get into trouble when they take an airplane. You may need to give them more oxygen. So this is something that you need to know. But it's not going to change while you are working in one particular location. These are non-variable factors. What can change is FiO2, because we can provide higher FiO2. So the maximum oxygen that can come in is 7 times FiO2 and PCO2. So if you 20% and then PCO2 of 40, maximum is around 100, and that's how we get this number. And then oxygen has to diffuse from here to here. If there are problems affecting alveoli, oxygen cannot diffuse. And then oxygen binds with the hemoglobin, right? Once it enters the blood. So if any kind of problem with hemoglobin can interfere with your oxygenation of the blood too. Right? So the factors that affect oxygenations are multiple: low barometric pressure, low FiO2, ventilation problem, diffusion problem, circulation both high and low, and then hemoglobinopathies. So just understand, hypoxemia has multiple factors, and you need to really know as a provider what is causing hypoxemia, because the management is going to be different. It's not same in all kinds of hypoxemia. Let me skip this. So ventilation is all about pressure and volume, right? Lungs basically, imagine lungs are like made up of zillions of alveoli. Each alveoli behaves like a balloon. Basically you are inflating the balloon. So when we inflate the balloon, in the beginning we put in a lot of pressure, it doesn't blow up. And then once it blows up, it is very easy for the balloon to blow up. So it's a compliance of that balloon, and the lung as a unit, we can look at it like a single balloon. So it works on the principle of pressure and volume. On the x-axis you have pressure, on the y you have volume. So in the beginning, you put in a lot of pressure, very little change in the volume. And once it inflates, this is what is the compliance of the lung. So that it's an S-shaped curve, right? Everybody. The point here, this is what we call is lower inflection point. The point here is, we call it upper inflection point. So if you allow the volume to go above this upper inflection point, what's going to happen? It's going to rupture. If you allow the pressure to go below lower inflection point, it is going to collapse. So your goal when you ventilate somebody is to ventilate somewhere over here in the middle part of it. You don't allow the lungs to collapse, because it has been studied and well known that if you allow the alveoli to open and close, that is what is associated with intense inflammation. All the inflammatory changes that you see in ARDS and pneumonia and in the lung is mainly because we are allowing the alveoli to collapse between each breath. So our goal is to keep the alveoli open, as many alveoli open as possible, and at the same time to prevent over distension. If you allow over distension, it's going to rupture and you will end up with pneumothorax. So we don't want to create any iatrogenic problem to the patient. So the best thing to do is to ventilate somebody over here in the middle part of the lung. And I will go through that, how to do that, how to achieve that particular goal. But that is your main goal of mechanical ventilation. So what is a ventilator? It is like a computer. It is a simple computer. It is a machine which basically is connected to the air and oxygen. And then you tell the ventilator what you want to ventilate. You want to either control the volume or you want to control the pressure. You cannot control both of them at the same time. You can only control one. Okay. And then if you control the tidal volume, the machine is going to build up a certain tidal volume. It is like a piston, and it is going to drive the tidal volume into the patient's lung. And depending on the pressures from the airway, the air has to pass through this airway. So there is a pressure applied by the resistance of the airway, and then the pressure that is required to inflate this lung to achieve that tidal volume. So eventually all this thing will be reflected, and then oxygen has to get into the blood. So this is basically what mechanical ventilation does, right? It looks something like this. So this is your inspiratory limb. It pushes air into the patient. Through the white limb, it is an expiratory limb. It goes back in the machine, and it's a closed system. Whatever goes in comes out. There shouldn't be any leak in the whole system. Okay, you can actually look at all the numbers on the side here, and your inspiratory volume should be same as expiratory volume. Okay, and these are the waveforms that you will frequently see on the machine. This is your pressure that is required to achieve whatever tidal volume you have. So this patient is on volume control right now, so every breath is the same tidal volume. Okay, but we will go through that. That brings us to the modes of mechanical ventilation. And as I said, you can either control the volume or you can control the pressure. You cannot control both at the same time. And now the terminology is very simple. Either it is a control mode or it's an assist mode. And it's very simple. You don't need your brain to an estimate, right? What is the difference between control and assist? In assist mode, patient is allowed to assist. Whereas in control mode, you are controlling the patient completely. So patient is not allowed to do anything, right? So in volume control mode, if you set the rate and tidal volume, set a rate of 10 and tidal volume 500, patient will get 10 breaths of 500. That's it. Nothing else. No more than that. Whereas in assist mode, patient can breathe more than 10 times a minute, maybe 20 times a minute. Then patient will breathe 20 times a minute, but each time you are still controlling the volume. So tidal volume will remain fixed. Okay. And with pressure control, same principles applies, and we'll go over each of these individually. Okay. So again, so in volume control mode, provider will set the respiratory rate, tidal volume, and FiO2. Flow rate, you cannot set the flow rate. Now with the newer machine, in the older machine, we had to set the flow rate. In the newer machine, you cannot. The machine will automatically calculate the flow rate depending on the compliance of the lungs. Tidal volume is always fixed because you are controlling it. Pressure varies depending on the compliance of the lung, right? That is simple. With every breath, your pressure is going to change if the compliance of the lung is going to change with every breath. It doesn't happen with every breath, but it is something that is a variable factor. It is what triggers the machine is basically in a volume control mode, the tidal volume. Once the patient reaches that tidal volume, the machine recycles, it exhales, and the same thing happens again. So the volume of the tidal volume is controlled by the machine. And the common modes are this: control mechanical ventilation, assist control, and SIMV. SIMV is synchronized intermittent mandatory ventilation. Nobody uses it anymore. Okay, some of the old timers, pulmonary specialists used to do it. That is a mode that is associated with the highest work of breathing. Our goal of mechanical ventilation when you provide to somebody is to reduce work of breathing, right? To take over the work of breathing because they've been working too hard. So we don't want to impose additional load by your ventilator management. So what are the limitations? If pressure required to achieve, you set a tidal volume, let's say 500, but then if your pressure required to achieve is way too high, your lungs are going to rupture. And we don't want that. We don't want to have that complication. Okay. So there is a risk of pneumothorax. If the ventilator, so what ventilator in volume control has, there is a limit. There is only a limit that the upper pressure the machine will deliver. If the pressure required is like more than certain number, more than 50, 60, whatever the therapist sets that machine to, then the inspiration will shut off suddenly. Okay, so patient will not get the full inspiration, but at least you will not create a pneumothorax. So on your pressure volume curve, you are preventing that over distension of alveoli, okay, by controlling the pressure. So it's a safety feature in volume control mode. Spontaneously breathing patients may be overventilated on a control mode because when you are controlling the tidal volume, remember every breath that patient takes has the same tidal volume. When you are breathing spontaneously right now, our volume may not be that high enough, but sometimes if we rate the volume to be very high, we can have too much minute ventilation for that particular patient's CO2 requirement. So this is what the graph looks like. So this is basically volume control mode, right? So this is pressure, this is volume, and this patient is set. So there is no patient effort. How do you know if there is a patient effort? Remember I just told you, when we breathe spontaneously, we have inspiratory muscles that constrict, diaphragm goes down, so it creates a negative pressure in the pleural space. And this is where you are going to see. You see there is no negative deflection here at all. So it is all positive. This is inspiration, this is expiration, and the tidal volume is fixed, all breaths. So patient is not doing anything here. Everything is set by the machine. Whereas over here, this is assist control mode, and you can see there is a negative deflection here. So this is what you are going to look at the mode. One of the answers I usually get when I ask residents, how do you know a patient is breathing along? You look at the pink sign. So in the machine we have here, there is actually, it shows as a pink sign that the breath was initiated by the patient, but we are getting new machines now. Actually, Woodhull got 28 new very fancy ventilators, which each ventilator is $30,000, so we are getting 30 of them. And those machines don't have pink sign. Okay. So you should familiarize yourself with actually what is going on. Okay, so you really are looking for this negative deflection on the pressure tracing, and that tells you that this breath is initiated by the patient, not by the machine. But even when the breath was initiated by the patient, what was the tidal volume? It was always fixed because we are controlling that. So this is volume control mode. All right. What do you lose on volume control mode is the control of minute ventilation. Okay, so if patient can become very, very alkalotic and get hyperventilated if you are not, used to it. Pressure control mode is you are going to set a peak airway pressure, respiratory rate and FiO2, and then your peak pressure is always fixed. So what is variable is your tidal volume. So since you do not have a control of tidal volume, you lose control of minute ventilation. So you don't have a control over tidal volume and minute ventilation both in pressure control mode. Usually it doesn't change from breath to breath, but the conditions where we use pressure control mode, things can get better over time. It can get better over very quickly, over a few hours, and your tidal volume may go way too high to create complications. Okay, triggered by patients or machine and limited by pressure. So basically pressure is controlling it, and these are the common modes. Okay. So what are the limitations? As I said, since tidal volume is variable and depends on lung compliance, right? So now you are setting the pressure, and the machine is going to deliver the whole pressure. So if the whole pressure is applied, if the lungs are very, very compliant, the tidal volume can go way too high, and it can over-distend some of the alveoli, and they can rupture. Unfortunately, the machine does not have the backup for this mode. There is no backup that your machine will not allow the tidal volume to go above a certain number. So, there is no backup in this, and if the volume goes up way too high, then you can develop pneumothorax. And that's why we don't like pressure control as a routine mode of mechanical ventilation. That's why we like volume control, because we have a full control over minute ventilation, and there is a safety mechanism. High airway pressure result in decrease in venous return and cardiac output. So if you use pressure control mode, you are always going to use a high pressure, and that is going to reduce the cardiac venous return, and it may affect the cardiac output if patient becomes hypovolemic. Okay, it is not very comfortable because the pressure you are going to use is always much higher than what is patient's baseline pressure. So this is what it looks like. So in control mode, you have set a certain pressure level, and your tidal volume may change depending on the compliance. Okay, over here again, patient is not doing anything. If patient is doing something, you will see negative deflection here. Okay, what is CPAP? So CPAP is kind of a pressure control mode where you are not controlling a respiratory rate or tidal volume. All basically it's a continuous positive airway pressure. So you are basically preventing the end expiratory collapse of the alveoli. Remember I said, you do not, I don't want to go back to that whole slide, but you don't want the alveoli to collapse. Once the volume goes down, pressure goes below a certain level, alveoli are going to collapse. So you want to keep those alveoli open. And that's why we are going to use some positive pressure at the end of expiration. This will maintain some alveoli open. Tidal volume, respiratory rate, and minute ventilation, all decided by the patient. Patient is going to decide how fast they want to breathe depending on the load on the system. And the load is determined by your carbon dioxide. If tidal volume and minute ventilation does not meet the required numbers, then patient will get tired quickly, right? Imagine if you are breathing. Remember, our tidal volume, the normal tidal volume is 8 ml per kilogram of ideal body weight, right? It goes by the weight. But when you are sick and you are not strong enough, if you're out of that tidal volume, 150 ml goes in the dead space. It stays in the upper airway and does not participate in gas exchange. So if your tidal volume is not high enough, it is less than 100, 150, then it is not achieving your actual alveolar ventilation. And you are not achieving your goal minute ventilation. So that patient can get tired very quickly. And you need to make sure you have some methods to improve that tidal volume. Okay, and that method is addition of pressure support to this CPAP. Okay, so how does pressure support work? So this is a CPAP mode, and basically it is cycled by the flow. It is just like a spontaneously breathing patient. This is what we are doing right now. And it generates some pressure and generates some tidal volume. If tidal volume is not sufficient, then you may get tired very quickly. Okay, so this CPAP is basically just the positive pressure at the end of expiration. You see every breath, you have a negative deflection in the pressure. So every breath is generated by the patient. Okay. And CPAP with pressure support, you basically are increasing the flow and demand level so that your pressure goes up, and as pressure goes up, your tidal volume goes up, and that makes the patient much more comfortable. This is probably the best mode that you can use in any patient who is breathing on his own. And if you achieve the patient satisfaction, this is the best mode to achieve patient satisfaction. Okay, because remember, when we put the patient on mechanical ventilation and we control something, then we are taking away patient's intrinsic drive. And sometimes in some patients, their personal drive is much higher than what you can provide him. That happens, they will have asynchrony. They will not be in synchrony with the machine. So your goal is to make sure that patients are in synchronous rhythm with the machine when you do that, because we end up sedating them and paralyzing them when they really don't need to be. You could use this simple mode to achieve patient ventilator synchrony. So going back, just revising everything we said, in volume control mode, things you control is tidal volume and respiratory rate. Things that you don't control is pressures, and what you follow is your pressures and minute ventilation. Okay, in volume assist, again you have the same thing, and you can read up this slide, but basically it's the same thing that we went over a few minutes ago. So once you put the patient on mechanical ventilation, you need to make sure that patient is tolerating it well, right? So you need to monitor the respiratory system. The things that you monitor on mechanical ventilation is the pressures on the machine. Make sure you look for auto PEEP on these patients every day. Obviously, your arterial oxygen saturation and the end-tidal CO2. If you have these devices, you probably don't need a blood gas on these patients every day if you have all this monitoring system in place and you know how to use it and interpret it. So, end-tidal CO2, basically the load of CO2, right? So CO2 is the end product of energy metabolism. Tissues produce CO2. It goes to the carried to the lungs and diffusion out of blood into the lungs, and lungs get rid of this CO2. So the only way you can get CO2 in the alveoli is the amount of CO2 that is brought to the lungs by the heart, right? So if you have a device that checks your CO2 level from the air that you breathe in and air that comes out, and it's a closed system, you can know that what is the CO2. It's coming only from arterial CO2, and that should reflect your actual arterial CO2. So so this is what the end-tidal, when we connect, when somebody is intubated, at the end of the tube, we connect a device which basically tracks your CO2. So in the beginning, as you inhale, there is no CO2. What we are inhaling is oxygen and nitrogen. In the beginning, when you start exhaling, is from point A to B, is the air from upper airway that comes out. So that did not participate in gas exchange. It was a dead space. So again, there is no CO2. As the air from alveoli starts coming out, the CO2 level starts rising. That's B to C. And then it plateaus out, because once all the alveoli has exhaled. So this point is called end-tidal CO2, and it should correlate with your arterial CO2. Because if you have a device, we have now enough devices to monitor patients' end-tidal CO2. And there are a bunch of other applications other than monitoring mechanical ventilation, but let's stick to mechanical ventilation right now. So if you have end-tidal CO2, we should use this in every single patient who is on ventilator. So you know what patient CO2. When you do a blood gas, it is just the CO2 at a particular point in time, whereas this is continuous. If you have something that gives you continuous number, you can't ask for anything better, right? So that's one of the monitoring device which should be using is end-tidal CO2, which will actually tell you actual alveolar ventilation that is going on. And then pressures. So the pressure that you see on the machine comes from two areas. It comes from the resistance, the air that goes from point A to point B. And remember, airway, when we are breathing right now, the diameter of trachea is 10 millimeters. And when you intubate somebody, we intubate them with 7.5 or 8 millimeter tube. So you already decrease the size. That is going to increase the resistance. Remember, resistance is inversely proportional to the fourth power of the radius of the tube. So, smaller the tube, the resistance goes up proportionately, and that induces some pressure on the system. So that pressure is called resistive pressure. And it is calculated, I don't expect anyone to know this or remember this, but it's calculated how fast the air is going times the resistance offered by the circuit. Okay. And then there is a pressure required to inflate this lung. which is basically the compliance of the lung. That is called the plateau pressure. It is depends on the tidal volume and the compliance of the lungs. So 4 factors are responsible for this peak pressure that you saw: volume, compliance, flow, and resistance. Okay. So in any patient, every time patient is intubated, how do you know which one is which? How do you, when the pressure number is, the machine is only going to give you only one number. It's your job as a provider to make sure which number is, how much is resistive pressure and how much is plateau pressure. And that is very easy to do. Okay. You can eliminate one pressure. And how can you eliminate? You make the flow 0. So you let the air go in and hold the breath. When you hold the breath, now there is no air movement going in. So the pressure is going to change, right? And the pressure, the machine will show you the pressure that is coming from just the lung. There is no airflow going on. That is how you know. So if patient is intubated for airway related problem like COPD or asthma, they will have a high resistive pressure but normal plateau pressure. Patient who is intubated for pulmonary edema or ARDS or pneumonia or something, they will have both high peak pressure with a normal, high peak pressure and plateau pressure with no drop when you put the inspiratory hold, when you stop the flow, because there was no change, right? And this is how, so this basically, everything we just talked about summarizes the whole thing. Now remember one more thing is, this peak pressure is also affected by the flow. If the flow you are pushing flow way too high, it is going to induce some increase in peak pressure. And that in select group of patients that may become a problem, but that's not something to discuss on the table here. You really need to be in presence of mechanical ventilator to understand the concept. So this is what happens. You allow this is your peak pressure. You allow the pressure, and when you put an inspiratory hold, the pressure will drop, and that's what is your plateau pressure if there was a lot of inspiratory pressure. So this is what the graph will look like on the machine, right? So what conditions will give you increased pressure, high flow, bronchospasm, COPD? So these are all the resistive pressure, and these are all the conditions that is going to increase your plateau pressure. Whereas increased plateau pressure is mainly chest wall and lung diseases, and increased total PEEP. Okay, so that brings us to the syndrome of auto PEEP. So what do we mean by auto PEEP? We apply certain PEEP, but then in most of the patients the patients may develop that you don't have enough time for patient to exhale your air, and every breath inspiration comes in before complete exhalation, and that is going to retain some air trapping in patient's lung, and that can induce what we call is auto PEEP. So PEEP will prevent collapse of the open alveoli and decrease distending pressure, decrease amount of inflammation, improve oxygenation by recruitment of alveoli, right? Reduce, it does have, PEEP does definitely has effect on venous return because it increases intrathoracic pressure. And then when you don't recognize this auto PEEP, it is going to have even higher or augmented effect on this venous, decreased in venous return. So it can affect when patient is developing auto PEEP and you don't recognize that, patient can remain persistently hypotensive and you don't know what's going on. You can fix that by just correcting this auto PEEP. Auto PEEP occurs when there is insufficient time for the respiratory system to return to FRC by end expiration. Basically what it means that you don't have enough time for the air to exhale. And the causes are short expiratory time, that is self-explanatory. High minute ventilation. If your minute ventilation is very high, again you are just breathing too fast, or increased expiratory resistance, and that is something that you don't know. Why patients with asthma, their main problem is end expiratory, right? The wheezing is more during expiration than during inspiration because they have a dynamic collapse of their airway during expiration. So that's what is causing their auto PEEP. And it does act like a PEEP to reduce all the cardiovascular effect. It is imperative to monitor auto PEEP in all mechanically ventilated patients. And how do you evaluate auto PEEP? Just like you hold the breath at the end of inspiration for plateau pressure, you hold the breath at the end of expiration in auto PEEP. And you see when your applied PEEP was 5, and if that number goes up to 7, 8, 10, then you have a 5 centimeters of auto PEEP. Okay. So this is what it looks like, okay, on the graph. So if this is your flow, you see this is inspiration and this is expiration, and expiration is not complete. Before it comes to 0, another breath comes in. So there is a small gradient between here, and that breath is going to stay in. And every breath, it keeps stacking up, and it's a domino effect. So eventually it is going to increase the pressure. Okay. So you can see that. So when you put an expiratory hold, this was a normal, you put an expiratory hold here, and there was slight increase in the pressure waveform. So these are some of the things that you need to monitor. End-tidal CO2, of course, your oxygenation, your pressures, your peak airway pressure and your plateau airway pressure. Because remember, the most common cause, if you are on call in the middle of the night and patient is doing well and suddenly peak airway pressure starts rising, you go to the bedside and you do this maneuver, difference between peak and plateau pressure, and you find a big difference, you know there is something wrong with the resistance, something wrong with the airway. So you start with suctioning the patient, take out the mechanical factors that is involving patient's ventilation, the ventilator circuit, the ET tube, and most common cause of this high peak airway pressure is airway secretions and mucus plugs. Okay, and that will solve most of your problem, rather than just going up on FiO2. Also, just few words about invasive versus non-invasive. If we should try to avoid mechanical ventilation in most patients. Try use non-invasive if you can. Certain conditions where non-invasive ventilation has been studied and shown to be very effective is CHF and COPD. In these conditions, there is no rush to intubate the patient if you can manage them with non-invasive ventilation. The only contraindications are if patients are very lethargic, not able to tolerate the mask, claustrophobia, and some of these conditions. With the newer mask, actually, they will usually do better. It can be used for temporary relief in mild asthma. We use it all the non-invasive. It is not really useful in patients with asthma, because in asthma the problem is more airway, not really lung. And with non-invasive machine, you are not going to be able to control the airway problem. Okay, so while you are treating, sometimes in some patients they feel better because they are getting more air. They typically have air hunger, and with positive pressure ventilation they can get more air, but it is not really recommended. And it's relatively contraindicated in patients with alternate mental status, vomiting. Of course, you don't want to use it. Pneumonia, and then excessive secretions. If you use it in excessive secretions, it is going to block the secretions to come out, and then that's going to make them more worse. So in pneumonia and excessive secretions, you want to stay away from using non-invasive ventilation. So some issues of mechanical, management problem is, you can get two concepts you need to know is the understanding of VQ mismatch and a shunt and VQ mismatch. So you have just on the graphic you have two alveoli here. One alveolus is normal and one is filled with fluid here. There is there is no oxygen over here, is all the way up here, and so you have venous blood on this side, venous blood on this side, and this is going to mix with blood on this side. There is no oxygen that came from here to here. It's a diffusion problem, right? So this blood over here is shunted from venous to arterial side without getting oxygenated, and it is going to mix with the fully oxygenated from this alveolus, which is going to bring the final oxygen saturation down. So this is hypoxemia. But this hypoxemia is because of the shunting of blood at the alveolar level. The problem is not ventilation here. The patient is being ventilated properly. The problem is oxygen is way too high and it cannot come down here. And how you can fix this hypoxemia is to recruit this alveolus which is not participating in gas exchange, right? The only way you can recruit this alveolus is by not adding oxygen, because even if you increase oxygen, the oxygen is all the way up here, it's not going to fix your problem. The only way you can fix this problem is by pushing this fluid out from this alveolus into pulmonary interstitium, and the only way you can do that is by addition of pressure. So you need to increase your PEEP. So remember, you can correct hypoxemia by increasing oxygen or increasing PEEP. And this is one condition where increasing the PEEP will fix your hypoxemia. Okay, so as a provider, you need to know what is causing it and what you can do to correct that hypoxemia. And this is what your X-ray will look like in these patients. If you have an X-ray like this and you're hypoxic, you are not just going to keep using oxygen, you need to use PEEP. Or this is the patient, probably you would use pressure control ventilation rather than volume control ventilation. Whereas a VQ mismatch where, both these alveoli are, there is no problem with gas exchange here, but alveolus B is not properly ventilated. That is because of bronchospasm or whatever is going on. The amount of air coming to alveoli B is decreased compared to alveoli A. So there is no problem with gas exchange, but patient is still hypoxic because the oxygen, not enough oxygen came from B to the alveolar capillary interface, and that brought hypoxemia. So if you increase PaO2 over here, you give a little bit of oxygen, it is going to increase the amount of oxygen in this alveol, even if it is hypoventilated, and oxygen can quickly, because of the gradient, can quickly come in and fix your hypoxemia. So if your X-ray is relatively clear, something like this, and patient is hypoxic, you can use oxygen to correct this hypoxemia, and that will correct very quickly. So these two patients with hypoxemia, but you need to manage them differently, and you need to be astute to figure out what you are going to use, either PEEP or FiO2. You may need to use both, but we frequently don't tend to use PEEP, but there are a group of patients where you need to use PEEP much more than FiO2 to fix their hypoxemia. And I just wanted to make sure that I pass this message across the board. So you don't just allow respiratory therapists to manage the ventilator, you guys participate in managing this machine stuff. All right, and the last thing is going to be weaning from mechanical ventilation. Remember, every foreign body in whatever we induce, every day you need to ask yourself, can this come out? And ET tube is one of those, right? So we introduced into it. So every day you ask yourself, can ET tube come out? Patient should be hemodynamically stable, of course. Underlying condition that cause respiratory failure should be resolved. Minute ventilation requirement should be acceptable within a reasonable range. Acceptable PF ratio less than 50%. Oxygen requirement is less than 50%. And your RSBI, which basically stands for rapid shallow breathing index, right? So how fast you are breathing. And the machine has a way to find out. So if you put the patient on CPAP, it will tell you how fast is the patient breathing and what is the ratio between tidal volume and the respiratory rate, and it should be less than 100. And then, you could use any mode. There was the biggest trial that we still kind of use it for weaning patients is, Esteban trial. He had 3,000 patients in his study, and he used all these different modes: SIMB pressure support, CPAP with pressure support, and then one group he just put the patient on T-pace. That means take the patient out of machine completely, let the patient breathe on his own without any kind of support, and watch them for 20 minutes and took the tube out. And guess which patient did the best? The patient who was on T-pace. So when you are ready, you are ready. There is no weaning. In majority of the patients, you don't need a weaning. But in some patients, since we intubate the patients and we keep them on the machine, remember, mechanical ventilation is like if you have a fracture of your arm or leg or something and you put yourself in a cast, the muscles will become weak. Then you need weak in 1 week, and then you need like 3 weeks or 4 weeks of therapy to get the same strength back. Same thing happens to intercostal muscles and diaphragm. They become weak, and you need this therapy, this exercise to bring them back. So the goal is to not control the patient completely at any point in time. Let the patient trigger the machine at all times. So that is one goal. If you allow the patient to trigger, they will not develop this level of weakness that they would if you keep them sedated and paralyzed at all times. So don't over sedate them. So we have a sedation protocol in place. So we should spontaneous breathing trial. Every day we should wake up the patient and let them breathe on their own. So that's what it is, right? And then we have a weaning protocol in place. So the therapist has the advantage of weaning protocol is the therapist will look at all these parameters, will change your mechanical ventilation mode, and you don't need order for every FiO2 and respiratory rate change. Other than non-invasive ventilation, the newer modes is, you could use high flow nasal cannula. This is another mode of kind of a mechanical ventilation. It's a low flow. I mean, it's a low level CPAP basically. It's a machine that gives you a flow at the rate 100 ml, 200 ml of minute that comes through a special machine and a nasal cannula. And some patients just like it. Some select group of patients, if you extubate them and they fail, you could use this mode to help them get over that immediate period post-extubation. And this has been studied in post-surgical patients, and respiratory failure post-surgery is a little bit different than what we are encountered in medical ICU. And this has been shown to be very effective in post-surgical patients, in surgical patients who fail extubation in your presence. Okay. Right. Any questions? All right. Thank you.